We're now going to begin the next section, section 2, which is a review of respiratory system disorders. The first thing I'd like to do is to give you an overview of the topics that we're going to talk about. Not only are we going to look at what the lungs do and how they do them, but those common recurring healthcare problems that will interfere with the body's or the lungs' ability to perform. We're going to look at diagnostic tests. We're going to look at labs that we evaluate the lung function or respiratory function. And we're going to look at those chronic recurring healthcare problems and the common ones, which are pneumonia, asthma, CAL, and the other common outcomes like bronchitis, chronic bronchitis, and right and left-sided failure as it occurs as a result of respiratory problems. So let's first just briefly recap anatomy and physiology. And I don't want to get into a great detail with this because anatomy and physiology is something that is your baseline information. But it's important to remember that when we look at what the lungs do, they don't just give us oxygen. They don't just take in oxygen, but they more importantly blow off or get rid of carbon dioxide. That means that they're maintaining that acid-base balance, that respiratory acidosis, alkalosis, they're preventing that. The other thing that happens is that they ventilate the body, which means that they get oxygen to all areas of the body. That's important for cell metabolism, for tissue growth, and so forth. And remember also that if you have something that is not functioning correctly, it's going to alter not just this system, but it will become systemic. Now, we know that in many of the conditions that we see in the hospitals today, they are related to things that will affect the outflow or airflow limitation, those things that will prevent air from getting into the body and, of course, leaving the body. Normally, when we look at the airway, it is always open, there should be moisture, the cilia should be functioning properly, and the body should be able to exchange gas at the cellular level without any difficulty. There are several reasons for this to not occur. The first thing is an infection. If you have an infection, it will increase mucus. It will also increase irritation, perhaps, and it will cause the body to start to deteriorate. And remember back what we talked about earlier on when we looked at the body system in failure. It doesn't matter what causes it. If there's not enough oxygen, the body is going to respond this very same way that we talked about in respiratory problems as it would in a cardiac problem. If you have a patient who has allergies and the airway is swollen, or the bronchioles or the alveolar sacs are swollen or edematous and not able to either expand and contract or exchange air, then again you're going to have a problem of airflow. The other thing that could cause, or the more common things that cause problems with respiratory systems are the obstructive disorders, as we talked about earlier, like COPD and bronchitis, and those things that we don't really think much about, which we call restrictive disorders, and they fall into the category of the patient who has ascites. They are a patient who has, a patient who's pregnant, by the way, also has the same condition, even though their condition is considered a normal one. They still have a problem of expanding and contracting their lungs because of a growing abdomen. So it's the same principle, whether it's because of pregnancy, whether it's because of ascites, whether it's because of obesity, they have a problem with restrictive disorders. Now, we'll look at diagnostic tests mainly in teaching the client what it is that they have to do to prepare for those. And of course, you're being able to evaluate the results of those so that you can implement your interventions. The more common ones that we'll see, of course, are chest x-ray and MAN2, or PPD, as it's called in many areas. The chest x-ray is a very common one. I'm not going to get into any detail about that, but the PPD, remember, is to evaluate a client for TB. Now, it's important to remember that if a client has had BCG, and many individuals who come from outside of the United States have received BCG, they will always be positive. They will always have a positive PPD, which is an evaluation for TB. which means that every 2 years they will then have to have a chest x-ray and a sputum analysis to determine whether in fact they are TB positive. With a PPD, remember, it is, I'm sure all of you have had one of those to get into your college when you went to nursing school. And so you had it on the anterior portion of your forearm, and if it's reddened or very edematous within 72 hours, you then have to have further analysis. So it is that type of an evaluation or that type of information. That sputum specimen or sputum analysis will only come after the PPD is positive. Now, this next part, I want to just remind you about this because we're going to talk about this again in almost every single section. When we look at some of these diagnostic tests, there are pieces of the word that will be the same regardless of whether they're talking about the lungs, the abdomen. It doesn't make any difference. The word centesis means to put a needle into a space and withdraw something. The word centesis means to withdraw, whether it's fluid, whether it is air. So the word thoracentesis then means to withdraw air or fluid from the thoracic cavity or the chest wall. Usually it's because you want to get a specimen, and it's almost always a diagnostic tool to determine whether there's any bacterial infection so that an antibiotic can be given. And so it's always done just as you would collect any specimen prior to giving any antibiotics. Because it's an invasive procedure, you are going to obtain consent. Now, I just want to again stop for one moment and talk about consent, because we're going to talk about it again when we look at pre-op and post-op, but remember, you are not obtaining it, you're witnessing the signature. The consent occurs between the practitioner, whether it's a nurse practitioner or the physician, whoever it is, and the client. You are merely observing that that signature is obtained and that the client doesn't have any expectations that are not spelled out in that consent form. Patient is positioned for a thoracentesis, usually sitting up at the side of the bed. They're usually over a bedstand and with their feet on the floor. As in any centesis, whenever you're removing fluid from a body cavity, and by the way, this also goes along with when we're looking at catheterizations, it doesn't make any difference. You're not going to draw off 2,000 or 3,000 liters or cc's of fluid at one time because it could cause a fluid shift. It also will cause muscle spasm and pain to the patient. So remember that you're going to, it's usually the parameter is 1,000 to 1,200 milliliters of fluid at one time. No more than that. Now you may see physicians doing that. The rule of thumb, however, is 1,000 to 1,200 milliliters at a time. After the procedure, there's a pressure dressing that is applied to the site of the puncture where the thoracentesis occurred. And again, remember, it's going to be in the thoracic cavity, and the patient's going to be, or the client's going to be kept in a semi-Fowler's position. Now, also important, because think about what else is in there. You need to look at what other organs are in the thoracic cavity. You have the potential for puncturing the lung, so you're going to be monitoring for shortness of breath, and you're going to be monitoring for an atelectasis or for a decrease in the ability to move air in and out of their lungs. And of course, shock is also important. Now, the other piece is subcutaneous emphysema. We talk about this, we're going to talk about it again when we look at chest tubes in a little bit, but subcutaneous emphysema is, it looks kind of like the little poppies that you wrap something up in when you don't want it to break. You're going to send it to your aunt or your uncle or whoever, and you wrap it in this material, and if you squeeze it, it will pop. What happens is that happens underneath the skin, and you'll feel it. It'll feel just the same way as that wrapping felt. That means that there's a leak of air underneath the skin. The last part of this is that the nurse will always need to assess for breath sounds. That's also going to give you an indication of whether, in fact, there is a pneumothorax or there is a problem with atelectasis and so forth. So assessment is always part of any post-procedure, nursing lung assessment. The next part of the diagnostic testing is the word oscopy, or the suffix oscopy. Now remember, I want to talk about oscopy because I think it's important to again, think about that this is going to occur. We're going to talk about this when we talk about the cardiac. We're going to talk about it in GI. So oscopy means putting a lighted instrument into an opening to view something. Putting a lighted instrument into an opening to view something. In this case, it's the bronchus, because we're talking about a bronchoscopy. Okay, so that's a little different than when we talk about the endoscopy procedures, which we'll talk about in the GI system. Because, again, there's a potential for an injury, again, a consent is needed, and the client will be NPO because, again, you're going to be using an opening, and in this case, they're going to be using their mouth. They're going to be going in through the oral cavity to view the bronchus. So because we're going to be viewing the lungs, it's important to remember that we have to evaluate or assess the status of the lung function prior to performing this procedure. Therefore, O2 status is important, ABGs are important, and usually a chest x-ray is also done. Post-procedure, because the tube, this flexible tube, is put down in through the oral cavity, it would be important to remember that their gag reflex has been inactivated. And how they do that is they actually literally put it to sleep. They anesthetize the back of the throat. Post-procedure, then, the client can't have anything by mouth until you're assured that that gag reflex has returned, that they can swallow and that they won't aspirate whatever the contents is that you give them. Vital signs are always done. And remember, any post-procedure, whether it is the thoracentesis, the bronchoscopy, the cystoscopy, vital signs are always a very good baseline measure of health or of homeostasis. Therefore, those are the things that would be monitored in all of these procedures. Whenever you have a client that has had anything that might be irritating, so for example, a client that has gone to the OR and has had a tube down their throat because they're on a ventilator, anytime, remember that to soothe that, it's the warm fuzzies. I call it the warm fuzzies because when you think about warm fuzzies, you think about something that's soothing. So warm saline gargles then would be appropriate. If you were to give them ice, it's not going to do anything. By the time it gets there, it's not going to anesthetize anything. That's usually for the oral cavity. So again, warm saline, those warm fuzzies. The other thing, of course, is that assessing of the lung function. So assessing for respiratory distress, listening to lung sounds or breath sounds, those are also very important. Clients should be in a position that would help them to maintain good aeration, and as we talked about earlier, semi-Fowler's position is also important, and of course encouraging them to take some nice deep breaths. The first fluid that you give them should be water, and the reason is because if they aspirate it, it is not as caustic to the lungs as perhaps apple juice or something that would contain other elements in it, so water is the one of choice. Important also to remember that any time you do an oscopy, an endoscopy, bronchoscopy, anything that's going into the oral cavity, because there's that risk of irritation, you may have some blood-tinged sputum after the procedure. Usually it's very minimal. It goes away. It's not an indication that there's an injury. It's just an irritation. However, profuse bleeding would require immediate follow-up. The first procedure, or the first condition that I'd like to discuss with you today then, is COPD, or chronic airflow limitation. It's now called CAL. It's not really one condition. Usually we talk about a group of things like emphysema, asthma, the problem of bronchitis, those types of things that would cause the lungs to not be able to exchange air and carbon dioxide, the O2 and CO2, and so they have a problem with getting rid of air or taking it in. The first one that I'd like to talk about is something called emphysema. We sometimes call this the pink puffer. And the reason that it's called the pink puffer is because with emphysema, the client can get air in. That's not the problem. They can take breaths in, But what happens is once the O2 and CO2 exchanges, they can't get rid of the carbon dioxide. Therefore, whenever you see retained carbon dioxide, the patient gets this ruddy complexion. It's a pinkish color, although they may still have circumoral cyanosis or a bluish discoloration to their lips. They still have that ruddy type complexion, thus the term pink puffer. Basically, what happens with emphysema is that the alveolar sacs lose their ability to adequately exchange air or oxygen and CO2 because there's a destruction of the alveolar sacs. So what happens is, in emphysema, the client will take in oxygen, and the alveolar sacs kind of get like a balloon that has been blown up 40 or 50 times. If you've ever done that, if you had an old balloon and you blow it up and then you let it go and you blow it up and you let it go, pretty soon it just kind of stays up. It doesn't really deflate all the way. That's exactly what happens in emphysema. The client's alveolar sacs expand, but they don't collapse all the way, and so they have difficulty expelling that CO2. Now, what happens? What happens or what causes that? The most common is smoking. When you smoke, it does decrease that elasticity. That's one of the most common causes. And remember that it is a preventable respiratory problem. It is the #1 preventable respiratory problem or cause of emphysema. We know also that there is a problem in some environmental conditions, such as working in a factory or living in an area that is very polluted, that could also cause emphysema. So this is not the only reason, but it is one of the most common ones. The very early symptoms, or those things that you start to see when the destruction becomes evident, is the client will become short of breath. They have a problem with exhalation. And because they have a problem with exhalation, we don't really even have to teach them how to do it, but they do something called pursed lip breathing. What that means is that the client will purse their lips, or it looks almost like they're ready to whistle, and they give short spurts of exhaled air. And that's because it helps them to get rid of a larger amount of CO2 every time they give one of those little short bursts of exhaled air. Therefore, that's called pursed lip breathing. The other thing that happens, if you've ever seen a patient with emphysema, you'll know because you'll never forget it. They usually are very emaciated looking, but they have a barrel chest. The reason they have a barrel chest is for 2 reasons. One, because all of that CO2 is trapped inside their lungs, and so the intercostal spaces separate and they cause the chest wall to get larger. The other, though, is that they're working very hard at breathing. You'll see them sitting up at the side of the bed. They're really pushing almost up on the bed, straining to breathe. You'll see neck vein distension, and of course this pursed lip breathing, that ruddy complexion that we talked about before, and usually circumoral cyanosis. Because they're working so hard, remember that working that hard at anything, like breathing, or if their heart has to beat extremely fast, it increases metabolic rate. Anytime you increase respirations, anytime you increase cardiac function, you increase metabolic rate. Therefore, you're going to break down your body stores of fuel a whole lot faster and lose weight. The other thing that happens is because they have a lot of oxygen on board, but they are able to take oxygen on board, but they're not able to get rid of CO2, they become hypoxic. So if I were going to evaluate or assess this client, not only am I going to see that circumoral pallor or circumoral cyanosis, but their O2 stat is going to be low. The traditional or the routine is that you'll see a client who has emphysema that is in the 83-88% range, which means that if I'm going to evaluate them, I'm not going to give them a lot of oxygen. Remember what we said their problem is. Their problem is they can't get rid of the CO2. They can take in the oxygen, okay. They can't get rid of the CO2. So if I give them too much oxygen, what's going to happen is they're going to have an increased amount of CO2 they can't get rid of, and so we're going to decrease their respiratory drive, and the client will die if I give them too much oxygen. So a client with emphysema then is given low flow oxygen, 1 liter. The other thing is there their O2 sat is going to be in that lower range, and that's normal for them. Now remember what we said earlier, that the O2 sat 95 to 100 is what we would like to keep it at, or anything over 93 is actually okay. However, in these cases, it's much lower. So that's a very important point that you need to remember. Also, they have a productive cough. And we're going to talk about that and how we can determine the difference between that one and the patient who has chronic bronchitis. It's a different type of cough. Remember we said it's productive, but although they're bringing up sputum, it's not as much as the client with chronic bronchitis. The other thing that happens long term, and again, it's not just for the client with emphysema, it's anybody who has a problem with oxygenation, is that the body tries to set up a collateral circulation, and therefore what happens is the client's fingers will club. What that means is that the body is setting up some peripheral capillary beds, some collateral capillary beds, and so that it would increase oxygen to the periphery. This happens in clients who have respiratory problems. It happens to clients who have cardiac problems long term. So that's not something that you're going to see in the first 6 or 7 months. But over time, you will see that. So that is, you know then that the client has had emphysema for quite some time. All the things we talked about before, all of those assessments that we talked about before are still important. You're going to make sure that the client can breathe very easily. So you're going to put them in a semi-Fowler's or high Fowler's position, whatever is most conducive to their breathing normally or breathing easier. You're going to give them oxygen at low flow, which is, again, 1 liter of oxygen, and you're not going to give them 3 and 4 liters because of what could happen with the CO2. Now, all of the textbooks, and this one included, talks about something called pulmonary toilet. And I've had students ask me this all the time. What is pulmonary toilet? And you know this already. You just didn't know that you knew that coughing and deep breathing is pulmonary toilet. In other words, flushing out or getting rid of whatever's in the lung fields is toileting it. In other words, getting rid of or excreting the excessive sputum and so forth. So coughing and deep breathing, putting them in a position where they can breathe more easily, giving them nebulizers, doing percussion, chest PT, and so forth, all of those things come under the term pulmonary toilet. So if you see that term again, you know what that means. The other, of course, is, remember what we said, that their metabolic demand is increased as a result of their increase in respirations. So these clients need frequent rest periods. Well, how is that going to affect your nursing interventions? Remember that you need to plan what you do for them so that you go in and do them all as a group. And then you get them up and ambulate them, and then you allow them to rest because they really are exhausted once you've even worked with them for 15 or 20 minutes. So they do need to rest in between, again, because of that high metabolic demand. Now, the other thing that would also be important in this long menu is that you need to give them fluids. Clients who have respiratory problems, especially with getting the problems of outflow limitation, they need fluids so that they can loosen up the secretions. The secretions will become thinner, and so you'll be able to more easily get rid of the secretions in their lungs. So at least 2,000 to 3,000 milliliters of fluid a day is important. Unless it's contraindicated because they also have congestive failure or there's renal failure. So we need to look at the client then who has multi-system failure. That may not be the parameter that we use for that client. We may need to give them less fluids. There are others in this menu. Again, those that I've mentioned, please put a star next to those. Those are the ones that are the ones that are the most common and those things that you should remember. The other things are also certainly important, but if you can only remember a few things, those are the things that you should remember. Now, the other really important part to this is teaching. And remember that a lot of the clients that we see are only in the hospital for a day or two, and then somebody's going to go home and take care of them, or they're going to have to take care of themselves. And we need to make sure that we know that they are comfortable with what they're supposed to look for, what they can do, their limits, and that's the big thing, because a lot of clients, especially those who have chronic conditions, don't want to admit that they have limitations. So avoiding crowds, because when we have a client who has emphysema, remember they are at high risk for infection because they have an increase in metabolic demand and because of all of the secretions that they already have. We also need to make sure that they know that if they're at the first sign of infection, if they start to develop a slight fever, if they start to have an increase in their cough, if their sputum changes color, those things are important to notify the physician immediately because they may need an antibiotic. And that menu that you saw a little while ago said administer antibiotics as necessary. The important thing is to identify the symptoms of the need for that antibiotic so that you can start it early on and that they don't get a full-blown pneumonia or other complications as a result of that. Remember also that whenever you're going to give an antibiotic, regardless of whether it's for a systemic infection, a respiratory infection, a urinary tract infection, always get the specimen first. Don't start the antibiotic before you get the specimen because it will alter the results of that. The next topic I'd like to talk about is chronic bronchitis. These clients are sometimes called the blue bloater. The reason that they're called the blue bloater, again, is because they aren't getting in enough oxygen. Remember, the client with emphysema was getting in the oxygen okay, just wasn't getting rid of the CO2. These clients don't take in the oxygen because there is an obstruction. I want to talk for just a minute about what that client looks like because I think if you get that mental picture in your mind, it will be very easy for you to determine the difference between these two disorders. Client who has chronic bronchitis, if you were to look at them from the waist up, they look almost emaciated looking. They're very drawn, they're cyanotic, they have circumoral pallor, their skin turgor is decreased. But if you were to look at them from the waist down, they almost look like they're puffy. And I always call it the Pillsbury Doughboy look because they look doughy. They're so edematous. The reason for that is because the excessive mucus secretions that they have in their lungs doesn't allow them to take on oxygen, and eventually what happens is you see the systemic effect of right-sided failure. Now, it's a slow process that starts to happen early on in the condition, and we'll talk about the end result in just a moment. Smoking is the major culprit here. We also know, of course, that chronic infection certainly could be another very real cause, and pollution is also. Copious secretions, copious sputum. The difference between the productive cough of the client with emphysema and the client who has bronchitis is that this is copious. They are constantly coughing and bringing up large amounts of sputum. The other is that they have dyspnea or difficulty breathing with even walking a few steps, and later in the disease, even when they're sitting in a chair, you can see that they're having difficulty breathing. They develop hypoxemia, and remember, let's take that apart again too, because emia means blood. Now remember, hypoxia means decreased ability or decreased oxygenation. Oxia meaning the circulatory portion of the oxygen level. Hypo meaning low levels. When you have hypoxemia, it means that you have low levels of oxygen in the blood. Now let's think back to what I talked about when we looked at perfusion. Remember what I said happens if I have a client who has a decrease in levels of oxygenated blood, whether it's because they have hypovolemia or because they can't get in enough oxygen. The body is going to do several things, and let's think about what those were. The first thing that's going to happen is you're going to see tachycardia. Then you're going to see tachypnea. Then what's going to happen is the peripheral circulation is going to shut down. They're going to have constricted vasoconstriction in the lower extremities. Eventually, they're going to develop oliguria and so forth. And remember, then eventually then the bone marrow is going to be stimulated to produce more red cells. That's exactly what's going to happen in this case also. These clients are going to develop those very same symptoms. So when we think about the client who has chronic bronchitis, that's the picture that you're going to look at. And if you follow through those symptoms, those are the assessment parameters. The important thing to remember here is that these individuals also are at high risk for infection, and whenever anything triggers that infection, it's going to increase their ability decrease their ability to take in oxygen. Therefore, you're going to prevent the exposure to irritants, and that is the number one nursing intervention. Prevention, remember, is always better than treating the disease afterwards. To prevent it from happening is much better than to treat it later. We're going to give them humidified air. And it's also very important that when you have these clients, these are the ones that you see that have the portable O2 tanks that they take around with them. You certainly see that with emphysema clients too. But they need to make sure that they have humidity. That little bottle that's bubbling, that fluid that's attached to it, the water, has to be there. And it makes sure that it's at the correct level, because if not, they're going to get even more of an irritation to their upper respiratory tract. Now, deep breathing, coughing, those types of things are also important. And chest physiotherapy. Now, remember the role of the nurse is provider of care, manager of care, and member within a discipline. So if I were going to manage this client's care, I need to make sure then that I give them the medication that they need before any other discipline comes in to administer, for example, chest physiotherapy as in respiratory care. Remember what chest physiotherapy is. It is making sure that the lung fields are excreting the secretions that are trapped inside. So we're going to give them their medication, their aerosol medication. We're going to then do chest physiotherapy, and we're going to make sure that they haven't eaten within an hour before or 2 hours after having this treatment. The reason is because what we're trying to do is have them cough. We want them to cough, and if they cough on a full stomach, they're going to vomit. And after they've coughed and all those secretions are in their mouth, they really do need good mouth care, because their appetite's going to decrease because they have that funny taste in their mouth. So that's also very important in managing their care. Now, a very similar type of condition or another respiratory condition that can have some similar symptoms is asthma. And that is a very common recurring healthcare problem, just as common, probably more common than bronchitis is, or the chronic bronchitis anyway. It is a condition that has hyperactivity or hypersensitivity to some type of irritation. Now, it could be that it could be an internal irritation, and sometimes we call that, it's intrinsic, which means that we don't really know what caused it. For example, a lot of athletes, young athletes, have that exercise-induced asthma. They exercise, and when they get to a certain point, they develop all the very same symptoms as a client who has asthma as a result of an allergen or a pollen or a medication or a bee sting. They develop all the very same symptoms. So we need to make sure that we recognize that it can be extrinsic, which is something outside the body, or intrinsic, which means that it's at the cellular level. We really don't know why the individual has it. The manifestations are twofold here. Not only do they have the physiological response, but they also have the psychological response. These individuals have a sudden inability to breathe. That means that they have a severe dyspnea. If you were to not be able to breathe, if somebody were to punch you in the stomach, you don't have asthma, but somebody punched you in the stomach and you can't take a deep breath, you panic because you think, I'm going to die. These clients they feel the same way. And so staying with them is extremely important, because they do have the feeling of impending doom. I can't breathe, I can't breathe. Therefore, somebody needs to stay with them. They're using all of their muscles of respiration. They're using all of their accessory muscles. They're sitting forward. Their neck veins are distended. They're pushing up on the bed. Remember we talked about that emphysema client. It's the same thing. They're exhibiting those same symptoms because they can't breathe. Remember, too, that if they're younger, and remember, asthma doesn't just happen in the young child, but it could also happen in the young adult and in the older adult. They may be using abdominal muscles rather than the diaphragmatic muscles, depending on the age group that the client is in. They are very diaphoretic because they are using, their metabolic demand is increased. When we increase metabolic demand, because our core body temperature goes up, we're also going to sweat. Therefore, diaphoresis is also present in these clients. And they are wheezing. Now, If a client is having a severe asthma attack, you don't really even need a stethoscope to hear them. Sometimes by walking in the room, you can hear them wheezing across the room. However, it is also very important to assess breath sounds to make sure that you recognize that perhaps all the lung fields are involved. Now, one of the things that you'll see is there may be an improvement in wheezing, but it could be that you may hear less wheezing, but then you don't hear anything at all. It could be that the condition is getting worse rather than getting better because you have a consolidation. The wheezing has stopped, but the alveolar sacs are so swollen that there's no air exchange at all. So you need to be monitoring oxygen saturation, and you need to be perhaps monitoring ABGs. Remember, ABGs are more invasive, so you'll see a lot more clients being evaluated or assessed using oxygen saturation. However, it's an important parameter to remember that not necessarily are they getting better just because they're not breathing. What you will see, though, is as you start to see it resolve, the client will develop something called an end expiratory squeak. That means that as they're exhaling, you'll hear this little squeaky noise, and that usually means that and you're not hearing the wheeze on inspiration and only on that little squeaking on expiration. That will give you an indication that the asthma is resolving. Now, you're going to put them in a high Fowler's position. That's very important. But the other thing is that we're going to have to not only monitor their respiratory status, but give them something to decrease the edema in those alveolar sacs. The first thing that we give is a drug called epinephrine. Now, epinephrine, remember, is given subcutaneously, and it's a bronchodilator. We're going to be monitoring the effects of that type of drug, and usually there's a protocol where it's given 3 times. You give 3 doses, and if there's no effective change in the respiratory status, then the client needs to go to an IV infusion of a drug called aminophylline. Now, aminophylline IV has many side effects to it. GI upset being the most common side effect. Very, very rare, although certainly it could happen. You may see seizures, but the most common is nausea and vomiting. Also important to remember that with aminophylline, aminophylline is mixed in a concentration based on body weight. So you would be putting in a concentration of aminophylline in a 500 cc bag of usually D5 or normal saline, and it is administered on a pump to monitor its infusion. You don't shut off the aminophylline, you don't piggyback anything into the aminophylline, and because the client, remember the aminophylline is what's keeping their airway open at this point. So you're going to be monitoring the progress, monitoring the client's respiratory status and the change. The other thing that is also given is corticosteroids. Now, corticosteroids are given for respiratory problems because of their anti-inflammatory effect. Corticosteroids are given for other reasons, and we're going to talk about that when we look at the endocrine system. Sometimes they're given in such small doses in the respiratory illnesses that they are not weaned off of them. Sometimes they are on larger doses, and they do need to be weaned off. The word weaned means to slowly decrease the dosage of the drug until they're taking none. For example, if I were to be given 5 milligrams 3 times a day of Solumedrol, then I would give 3 milligrams for 3 days and then 2 milligrams and so forth until I'm given none. Now, the clients usually will go home. We switch them from IV medication to by mouth medication so that they are given a schedule so that they can determine how much to take each day. But again, this is for the anti-inflammatory effect. The other is that we use in this type of illness is a bronchodilator. The bronchodilators are, we'll talk about that again in just another couple of minutes, but bronchodilators, again, dilate the bronchioles, which will increase the surface area for the CO2 and O2 exchange to occur. Another disorder that we mentioned at the beginning that we'll be talking about is something called CAL, or chronic airflow limitation, previously called COPD. In this case, the reason we're talking about it with regards to the respiratory system is because the problem that a client has who is a chronic bronchitis client happens is something called cor pulmonale. Now, cor pulmonale is something that we see fairly frequently, and it looks exactly like right-sided failure. So we're going to talk about it again more in depth. I'm going to refer back to this when we talk about the cardiac system. It is right ventricular hypertrophy that occurs as a result of the disease of the lungs as this chronic bronchitis client. And you see this, remember what I said to you earlier, that initially when we saw the chronic bronchitis client, we saw them and they started to get edematous. Remember, from the waist up, they looked emaciated. From the waist down, they looked very edematous. That's because the right-sided failure starts to occur, and that's as a result of cor pulmonale. The vascular beds get smaller in size, therefore they retain the fluid. And of course, when you see right-sided failure, you see distended neck veins and so forth. So again, remember that you need to make sure that you look at the systemic changes that will occur because the client has right-sided failure. Now, the other thing that happens is these clients have, again, an increase in metabolic demand. So we want to make sure that we give them adequate rest. They need to stay on bed rest or at least limit their activities, especially when they get to this stage. Oxygen therapy also needs to be initiated if it already hasn't, and most often it has been. But again, you're going to be monitoring the oxygen saturation and making sure that the client is receiving the oxygen level that has been ordered. 2 liters, 3 liters is usually the common order for oxygen. Another thing that's important is low sodium. And the reason that it is important is, again, because of the fluid retention. They are edematous. They become systemically edematous, especially in the lower extremities. And so restricting sodium would help to prevent additional fluid from coming on board. These clients also, because they have right-sided failure, they will be receiving a drug called digitalis and diuretics to get rid of some of the excessive fluid. We'll talk more about digitalis when we talk about the cardiovascular system, but remember that when we give a diuretic, we need to make sure that we monitor whether it is a potassium depleting type of diuretic or whether it is a diuretic that does not deplete potassium. The next topic is carbon dioxide toxicity or narcosis. This occurs very often in clients who have emphysema because they retain CO2. It is certainly, it happens to, if an individual were to be in a room where they've been deprived of oxygen, they may also have a carbon dioxide toxicity. But this client has signs of hypoxia. Think again back to that emphysema client that we talked about and what they look like. This is the initial stage. This is what they look like at the very beginning. Eventually, because they're hypoxic, they have those central nervous system symptoms such as drowsiness. They become irritable. They have hallucinations and eventually will go into a coma if there is no intervention. Now, the other signs and symptoms that you see are signs that are not they're late in the symptoms or in the progression of the disorder. However, tachycardia becomes number one. Tachycardia becomes number one because remember what we talked about when we looked at perfusion. What happens first? The client will develop a rapid heart rate and tachypnea anytime you have a problem with oxygenation. So that's going to happen in this case as well. These are the clients that we talked about that you don't give high levels of oxygenation to. You need to make sure that you monitor how you deliver that oxygen. You keep them, don't ever give them more than 3 liters, and usually they're at about 1 to 2 liters of oxygen. And we don't give them 100% oxygen, but more around the 60 to 70% of oxygen delivered. That's also a very important point because the higher concentration of oxygen given, the more CO2 that they will retain. Also remember that you know what type of delivery system that is delivering that oxygen that you're supposed to use because some of them give a different concentration of oxygen. For example, a cannula will give a 40% O2 delivery rather than if you give it by mask, it's a higher concentration of O2. The other thing, of course, is monitoring the response, the O2 sets, ABGs. Those are the types of things that will tell you whether the client is responding or not. Now, they're not going to ask you about what type of oxygen they're getting. But what they're going to say is this client has emphysema, is getting 2 liters of oxygen. Which of the following will tell you whether oxygen therapy has been effective? And they're going to give you a couple of things, and one of them will be that you're going to monitor their O2 sat, or you're going to look at their ABGs, and they're going to be within normal range. Or they may give you urinary output and all of those other things, but remember that what you're going to monitor is ABGs or O2 sats. Now, a pneumothorax is another one of those respiratory conditions that are fairly common, and we need to talk about those because, again, common recurring healthcare problems are what you will be tested on. This is a collection of either fluid or air in the pleural space because of a change in the pressure within the lung. Now, how does that happen? Well, it happens for a number of reasons. Traditionally, we think of trauma like a gunshot wound or stabbing, but it also could be when you've had something that is called intentional trauma, which is like thoracic surgery, and it's what happens is the intentional trauma occurs and the lung responds negatively to that intentional trauma. Another thing that is something that we need to be very aware of is whenever you have a client that is on a respirator, positive pressure ventilation is although it's not, I should say it's a common cause, it's a common type of therapy. So we need to be astute and be monitoring these types of clients for the potential for pneumothorax. Remember that air gets in the cavity and causes the lung to collapse because you have a change in that pressure gradient, and that's very important. It goes from a negative to a positive pressure. Now, what happens also is you could have a type of condition that is what we call iatrogenic. And iatrogenic is a very general term. It simply means that it is something that occurred as a result of something else. For example, that thoracentesis that we talked about, remember the centesis, putting a needle or a trocar into a space to withdraw air or fluid could have caused nicked the lung or the pleural cavity and caused the lung to collapse. Another thing that could happen, of course, is that when we put in a CVP or central venous pressure IV, or central line or central venous pressure monitoring, remember where it's going into. It's usually going into the subclavian vessel. Now, there are other ways. Certainly, we can use other vessels. But when we do use the subclavian, we're going right over the apices of the lung. Very often, I shouldn't say very often, but it could happen that the top of the lung is nicked, and again, a pneumothorax will occur as a result of that. So, again, it's because of something that is therapeutic, perhaps, that has caused this. Now, there are some that are unknown, and one of the things that falls into that category is the congenital type things. For example, they could develop a congenital bleb, and if they exert themselves too much, as in the case of a 17-year-old that I took care of not too long ago that had he was singing in a choir, took a deep breath in, and all of a sudden he collapsed. And we'll talk about what the symptoms were, but the end result was that he'd wound up with a chest tube, and it was because he had a congenital bleb that burst during that extra inhalation that he did during the time when he was in the choir. Now, there are 2 types of pneumothoraxes, spontaneous and tension. Now, tension pneumothorax is because there's a lot of pressure that's built up. Remember what we said, that it's going to be changed from a negative to a positive pressure within the pleural space. This is a very serious condition because the other things shift as a result of that change. All the other major organs also will shift. So we're going to talk about what the client looks like who's had a tension pneumothorax and a spontaneous pneumothorax. Now, what happens when you see a client with spontaneous pneumothorax? They will be taking a deep breath in, and again, the key word here is sudden. So I'd like you to underline that. Sudden, sharp chest pain. Sudden. 1 minute they're fine, the next minute they take a breath in and they have this extreme, severe pain. They become dyspneic or have sudden shortness of breath, and they can't breathe. They're gasping for breath. And it's because, again, they have one of their lungs is no longer functioning. Because they have a decrease in oxygenation, that the hypotension and tachycardia also develops. Now, When we looked at that, remember perfusion again. We're going to go back to that same thing that we talked about before. Perfusion is extremely important to remember because this is exactly what's happening here. Now, if you were to listen to the lung fields, you're going to hear all of that air in the pleural space. You won't hear in and out, but you'll hear a hyper resonance or a very high-pitched sound that you wouldn't have heard. You would have heard that in and out breathing. You're not going to hear that. On the side that the pneumothorax has occurred, you may not hear anything at all or a very minimal or decreased breath sounds. The client is extremely anxious. Remember, they're frightened. There's that psychological piece that says, I can't breathe, just like we talked about with asthma. It's the same thing in this case. Now, with tension pneumothorax, what's going to happen is you're going to start to feel a leak. You're going to see the signs of a leak because air is escaping from the lung underneath, into the pleural space and sometimes underneath the subcutaneous tissue. So remember we talked about subcutaneous emphysema before, that stuff that feels like little poppies under the skin. That's the same thing that occurs here. And of course, cyanosis, dyspnea, those things don't change. Tachycardia, because it's a problem of perfusion, oxygenated blood. There's not as much oxygen in the circulatory system. Now, if I were to have a client that I suspected that had a pneumothorax, what I would do is take off their shirt. And the first thing I would do is look at their chest wall. And if I don't have to do anything else, if they truly have a pneumothorax, because by looking at them, I can tell that there's a problem. The first thing I'm going to see is that their trachea is going to be deviated to the unaffected side because the expanded lung, we'll say that it's the right lung that is collapsed, the left lung is expanded, the trachea is going to go towards the expanded lung. In addition, the PMI, or point of maximum impulse, that apical pulse, is not going to be where it was supposed to be. Remember back from when you did assessment, the PMI is fifth intercostal space midclavicular line. It may be under their armpit. It may be deviated all the way to the left. Again, if it's the other side, it may be deviated under the sternum rather than where you would expect to find it. In addition, think about what else is in the chest wall. All of those organs are also going to be moved. And you're going to, again, see that the lung that is expanded is fuller, and you'll hear no respiratory effort, no breath sounds on the side, the affected side, and an increase or hyperaeration on the unaffected side. So the tracheal deviation and, of course, cyanosis are what we would look for. Now, these individuals are, again, frightened. You're going to stay with them, just as we talked about, and you're going to prepare them for a chest tube. That is the only intervention that is going to help this client to recover from this pneumothorax. First thing that will happen is a chest x-ray is done to determine whether this is in fact the problem, whether there are other things that are going on, whether there's fluid in the chest wall, blood, or whether it's all simply air that has been escaping. Vital signs and baseline assessment are always important. Vital signs, breath sounds, those are the things that we do routinely whenever we have a client who has had some type of trauma or who has a failing system. The next thing is a thoracentesis. And remember again what the thoracentesis is, removing fluid or air from the pleural space by inserting a needle and aspirating it out. Remember, what we want to do is reestablish the negative pressure within the pleural space. Okay, reestablish negative pressure. Or we want to relieve that pressure from the tension pneumothorax, as we talked about earlier. The next thing that we're going to do is monitor them for shock and assist with this chest tube. Now, I don't know if you've ever seen a chest tube inserted, but remember that there are certain things that will occur that may be very frightening to this client, especially if they're alert and awake. So your role then would be to maintain your contact with the client, make sure that you stay calm, and remember to make sure that the client gets medicated. And we're going to talk a little bit more later about medicating them for pain, especially during the post-op period. But these clients, if you can be their client advocate and make sure that they anesthetize them in some way. Certainly they may not be able to give them anything systemic, but at least a local anesthetic, because it is a long trocar that is put into the pleural space to relieve this pressure. Now remember, it is a trocar that goes into the pleural space. It doesn't go into the lung. It's changing the pressure gradient in the pleural space. The client might have 2 chest tubes or 2 stab wounds. Think about what happens. Air floats or air rises to the top. So if you have only one, it's going to be in the upper portion of the chest wall because air will rise, and that's how we're going to evacuate the air. If there's fluid or blood in the chest wall, you're going to have the lower one or the tube will be lower inserted because we know that that will get rid of the fluid or because it will sink to the bottom, and so we're going to put the tube in that area. Now, there also is an occlusive dressing over that. And your role is going to be, again, to assist to make sure everything is all set up and then to monitor this after it's been inserted. We're talking about this because we need to talk about chest tubes. And remember that there are many names for it, and there are many brand names, but it is a closed chest drainage system. That's the general term. It doesn't matter what type you use because they're all different in all different institutions, but the principle is the same. We use it to either remove fluid or air from the pleural space. That's the reason that a chest tube is inserted. We also know that we need to reestablish that normal negative pressure in the pleural space and to make sure that the lung can expand. And those are the 3 most important reasons that we put in a chest tube. Now, the occlusive dressing that's put on and the tube in and of itself, when it stays in place, actually prevents air from going back in, or air reflux from going back into the lung and changing that pressure. Now, the general principles that you need to know about are very, very simple, but I'm going to first have you look at this diagram that we're putting up on the screen now of a chest tube drainage system. Now, this doesn't have a brand name, as I said. It's a closed drainage system, and they all look very similar. There may be some different bells and whistles on them, but they are all the same principle. The first thing that you need to ask yourself is, where is the water seal? Most of them have 3 chambers to them, even though you may not use all 3 because you may not use the vacuum seal. But the water seal drainage is always in the center. It's always the one that's in the middle, and the way that we maintain it is by how much fluid is actually in that chamber. So that's one of the things that you need to know. Now remember that water will evaporate. Therefore, part of the assessment that you will do is every shift, at the beginning of your shift, you'll go in and you'll look at what the level is to make sure that it is at the prescribed amount. The second thing is, what is the area, what controls the suction in this system? Is it a gravity? Is it a negative pressure? And what is the setting? And that's very important. Now, if there is no suction attached to this, remember the suction is what's going to be the farthest away from the client. So that's the chamber that you're going to look at, and there will be continuous bubbling in that chamber. There's going to be fluid in there. It's not what you're collecting from the outside. It's going to be fluid that is that you have instilled. Again, that too will evaporate, so you need to make sure that you monitor the amount that's in there, and of course the control settings that are also to make sure that they are also at the appropriate level. Now, we talked about that water seal drainage system, which is right in the center. Think about what happens to that it is controlled or modulated by the client's taking a breath in and out. So when we look at the water seal drainage system, and the water seal chamber, we're going to look at whether there is when the client has an inspiration and expiration, there should be an up and down movement of that fluid, and that's called titling. That is called titling, and that's something that you would expect to see in that middle chamber. Remember what we said about that outside, the chamber that's the farthest away from the client is the one that we use for the suction chamber. Remember whether if it's a hooked to wall suction or if it's just a gravity flow. That chamber will be continuously bubbling if it's hooked to suction. And that's something that you would expect to find. The one that's closest to the patient is going to be the collection chamber, or that where the chamber where the drainage is collected. Your role for assessing this is to determine whether, in fact, the level has risen since the last ship. So what you'll do is you'll mark it. Used to be that we used to empty them. We don't do that anymore. We just simply mark it for that ship. So you'll put the time on it and the date, and you'll make sure that you monitor the level of that. Now, also important is that when you measure, so you're measuring that drainage, and you also need to remember what you need to keep at the bedside. And we're going to talk about assessing this type of system in a moment, but at the bedside there are a couple of things you need to keep. One is a bottle of sterile water or sterile saline. The reason is, should the collection chamber become broken or dislodged in some way, the end that is not in the patient, the one that's in that collection chamber, can be taken and placed in that sterile water, and you would maintain that water seal. Because remember, this is a water seal drainage system, and that means that the level of water determines the seal that is occurring in that chest, in that lungs field, or in the pleural space. The other thing that you need to have at the bedside is a rubber-tipped clamp, so that when the chambers become full with the exudate or the drainage that's coming from the lung, and you need to change the entire system, you have the equipment readily available. So what you'll have is the rubber-tipped clamp, so that you can clamp the tubing off, clamp the chest tube off, change the system, and then reapply it and then unclamp the tube. So those are the two things for safety. Those are the overriding safety things that you need to keep at the bedside. Now remember, the type of thing that you saw in that diagram, that type of collection device is what has replaced all the 2 and 3 bottle chamber systems. We don't use bottles anymore. Occasionally you may see a 1 bottle system that we use sometimes when we have a client with empyema, where all of the drainage and the water seal is in the same bottle, but that's very rare. Usually you see the 3-chamber collection system. Remember that, again, the suction is controlled by the amount of water that's in the suction control chamber and by the setting. So you need to make sure that you know that before you go in and assess the client. Now remember, I said to you that there were 2 things you needed to keep at the bedside. There is a 3rd thing that also needs to be kept at the bedside, and that is an occlusive dressing. Should that chest tube become dislodged or come out of the client's chest wall, you need to have a sterile occlusive dressing that you can open and apply immediately to the opening, so that you can occlude the area, and then of course call the physician, because that chest tube may need to be reinserted. That does happen. Clients don't always stay where you want them to, you know. Even though it's sutured into place and the occlusive dressing is on it, they may turn over and dislodge that tube. Now, what I tell my students, what I tell all of the students when I go across the country for meds and teach them about this, is that the client is what you need to assess first. So if I have a client that has a chest tube, I'm going to go in and first listen to lung sounds. I'm going to make sure the client is breathing, because it doesn't matter what the chest tube is doing or the IV or any of that. If a client isn't breathing, it makes absolutely no difference at all. So I'm going to listen to the lung sounds. I'm going to make sure they're breathing, and then I'm going to start at the client. And if I look at where that occlusive dressing is at the insertion site, and I check it to make sure I don't see any subcutaneous emphysema, it's the same thing that we talked about when we looked at before, that stuff that feels like little poppies under the skin, same exact thing, because that means that there is a leak with that tube. If I don't feel any subcutaneous emphysema, if that that occlusive dressing is in place, then I go through the entire length of the tube till I get to the collection chambers. Sometimes what will happen is the client will roll over in the night, kink off the tube, so that if I evaluate the client and start with them and go right down to the system, the chances are that there is no kink in the tube, which would cause a change in the bubbling in the water seal drainage system. And if there's a leak, I will also know it. Or if it became dislodged, I would know that. Sometimes what would happen is we want to give the client a little bit more room to walk around. So we tape a number of different lengths of that tubing together. You need to make sure that they are also adequately taped together. So that is extremely important. Another thing, remember we talked about manager of care. If the client has a chest tube and a chest x-ray is ordered and there is suction in place, we need to make sure that we have a physician's order to discontinue that suction to send them for a chest x-ray, or managing their care, we would order a portable chest x-ray at the bedside. And that is a very important point because you don't want to interrupt the expansion of that lung. Now, it could very well be that what will happen is, as it starts to resolve, you'll see a decrease in that titling. You'll see it won't tidal as much because it's resolving. The chest has fully expanded, and that means that pretty soon that client's going to get rid of that chest tube. When you first put the chest tube in, what also will happen is, remember why we're putting the chest tube in, to get rid of the air or fluid. Well, sometimes in that water seal drainage, you'll see a lot of bubbling initially. And after a couple of hours, you don't see it anymore. It's gone. So therefore, that would be a normal event in the beginning or in those first couple of hours. 4 or 5 hours later, that wouldn't be a normal event, and you would have to look for either a leak, or if there's a problem with the chest tube, you may have to call the physician. So it's important to be able to evaluate that accurately and know when to expect bubbling, what chamber you're expecting it in, and when it's in a normal event or whether it is an abnormal event. The next topic that we'll talk about is infectious pulmonary diseases, and one of the most common recurring healthcare problem that we are facing today is tuberculosis. We know that it is on the rise, although in the 50s we had almost completely eradicated it. It's now back on the rise again, and the reason for that is because of the type of clients that we're now seeing. Certainly the patients who have HIV also contribute to this growing population, but transient population, overcrowding systems, overcrowding conditions, close quarters, prisons, which we know are increasing in numbers, all of those contribute to the spread of this type of communicable disease. Remember, it is an infectious, inflammatory disease that can occur not just in the lungs, but you could have it in the kidney and elsewhere in the body. So it's a misnomer to think that tuberculosis is merely a lung disorder. However, this is where we're going to talk about it. Now remember what we just talked about, those risk factors are that the overcrowding, the transient population. One of the other things that also contributes to the spread of this is noncompliance with the treatment for TB. We know that because we have a transient population, they may not take their medication the way they should. They don't come back for follow-up, or they move from place to place, and they are very poor reporters of who they had contact with, so the disease may have spread to individuals that we have no knowledge of. We also know, of course, that the elderly are at high risk, and with the onset of the resistant types of illnesses to antibiotics, we know that TB also falls in that category, and so it becomes much more widespread as a result of that. Now, the symptoms or manifestations that we see are the same as any of the other pulmonary symptoms, but there's one that kind of sets this one apart. Certainly, they're going to have a cough, and it's productive and does not just occur during the day. It may keep them up all night. One of the other things, however, is night sweats, and that can be attributed to certainly other diseases, but when you have that combination, this is very often going to lead you to looking for the diagnosis of TB. Hemoptysis is also another symptom, and remember, hemoptysis is where you see blood in your sputum. Now, we're going to talk about other lung disorders, and that also is common in, for example, lung cancer, but coupled with all of these other symptoms, it would also lead you to TB. Later on, you would see anorexia and weight loss. Those are very late symptoms. The others that we just talked about, those are the early symptoms, and those are the ones I would star, because if you have a client that has TB, you're going to see them hopefully in those initial symptoms. The diagnostic tests are those that we talked about at the very beginning of this section. The MANTOO or PPD, which is the test for by using injecting live virus under the skin or virus under the skin and looking for a reaction. Those are some of the diagnostics. Certainly sputum for acid-fast bacilli and chest x-ray. The other really important thing is the history. and what they look like. Where were they? Where do they live? Are they in a prison? Are they a transient? Are they HIV positive? Those are the things that we need to also look at, and that will contribute to our looking at the client who has TB. Now, the treatment is very, very important. So this is the section I'd like you to pay particular attention to. Looks more at the treatment than at the assessment portion of this type of disorder, because we look at compliance and the effect of these drugs on the client. Now, all of these are called chemotherapy. We talk about chemotherapy when we look at drugs that treat a specific illness. So this is not the drugs that we would use for example, cancers, but it is still called chemotherapy, and they are all hepatotoxic. So when we are looking at assessment parameters, if we're going to look at the whole picture, then we're going to have to look at those indicators that would tell us whether the liver is involved or not. So remember that these are the drugs that you need to look at. Those are the evaluation procedures that you need to employ when we're looking at these types of patients. Now, there are 3 drugs that are mainly used, 3 of the major drugs. There are others that are used. If the client is non-compliant with this regimen, then they go to those drugs that are not as effective. But the ones that are the most effective are ethambutol or myambutol. And the one thing that would stop the client from being able, or prevent the client from being able to take this drug, is if they started to develop optic neuritis. You know, questions about the signs and symptoms when you're giving a drug, the side effects, what the client will present with. And some of them are expected or minimal, and so the client would not, you still would tell them to continue the drug, and that may be one of the responses. They will either continue the drug or they'll have to change to a different one. In this case, if they developed a skin rash, you would still continue the drug. However, if they have optic neuritis, they may need to have a different drug included in this regimen. Rifampin or rifampin is a drug also that is used in conjunction with all of these 3 of these drugs that I'm going to talk about are all used together. And rifampin is one of those where it will turn the body fluids it's really kind of an orangey color, and it turns urine, feces, sometimes even tears, this peculiar reddish-orange color. But because that happens, it's not enough for us to stop the drug. In fact, we just need to make sure that we tell the client that in advance, that if this does happen, let us know, but it's not anything to worry about. It is a mild side effect. However, if they were to develop thrombocytopenia, then remember that is something that would require some type of intervention, because they now are at high risk for infection and so forth. The other drug is INH, or isoniazid. And isoniazid is used also in conjunction with the other 2 drugs that we talked about. It is hepatotoxic. And so if this client starts to show symptoms of hepatotoxicity, again, we may have to either alter the dose or change that drug. Peripheral neuritis is also fairly common, and it may, depending on the extent of it, it may or may not be a cause to stop that drug. However, one of the things that we can do to minimize that is that we can give the client B6 or thiamine. B6 or thiamine will help to decrease that peripheral neuritis and decrease the effect of INH on the nerve fibers and so forth. So we always add B6 with INH whenever we're giving this regimen of drugs. Now, very often, if those drugs don't work, we may add a drug called streptomycin. Streptomycin is a very caustic antibiotic, and it does affect the 8th cranial nerve, and so it may even cause permanent damage to it. So we are very cautious when we use streptomycin. The other thing is that if a client has renal failure, or if they have problems with the glomerulus of the kidney, we would use it very sparingly or with extreme caution. In fact, probably not at all in these types of clients. Now, prevention, again, is important with TB. The client needs to prevent the spread of infection. Now, to talk about preventing the spread of infection, and the way that they do that, certainly we talk about hand washing and all of that with our own practice, but remember that you're going to be teaching the client there too, washing their hands, making sure that they know where to dispose of their tissues, making sure that they dispose of them appropriately to, again, prevent the spread of this disease. The other thing that's also important is that these drugs are they're given on an empty stomach, and initially they're given 2 or 3, they're given for a couple of times a week, and they are going to be given on an empty stomach, and usually at the same time each day. And that's also very important, that it's because it will promote absorption of this type of these drugs. Now, they have to be taken for a long period of time also, and that's that compliance issue that we talked about. They're going to be taken at least 6 months, sometimes up to a year, and so if the client is a transient or isn't in a place where we can keep track of them and make sure that they're taking the drug, that's when they have a multi-resistant strain of TB. Now, when there is an active TB, the client needs to be on bed rest, again, to decrease metabolic demand. And I've said that several times, but I want to remind you that whenever you want, in a question, if they're ever asking you about what do we do to decrease metabolic demand, we always put the client on bed rest, whether it's post-op, it doesn't matter what the reason, whether it's for this type of condition, that's the reason for putting them on bed rest. Now, we also know that they have to you're going to be monitoring their liver function, and so they have to come back every couple of months to have that done. Now, when we take care of a client who has TB, there are several precautions that we need to take. One is that they are in a negative pressure room, and remember that when they're in this negative pressure room, it means that the air exchange occurs within that room, so the door has to be kept closed, and it's filtered so that whatever the bacteria is that's in that room, it stays there. Remember that TB is passed or spread by droplet infection. That's why we teach them about hand washing, disposing of their sputum and so forth in the appropriate receptacle, because that will help to prevent the spread of this infection. If you're taking care of this client, you're going to be using something called a particulate respirator mask, and some of you may have seen this already. It's an occlusive mask that forms a seal around your nose and mouth, and some of them have little valves on the other end, some of them don't. You have to be fit tested, and there's this procedure that each institution uses to fit test, which means that it's a nice, big, great seal, so that you're not running the risk of having those TB bacteria inhaled in, and that you are now not at risk for getting TB. Now, if an individual, I'm the care provider, and I have asthma, I may not be able to take care of a client with TB because that may be too restricting, and I may not be able to breathe using that. So that may be prohibitive for those practitioners who have some type of restrictive disorder of the lung. The other thing is that when you enter their room, you have to wear a mask. If the client who has TB is coming out of their room and going, for example, to x-ray, it's the client that wears the mask, not you. You're preventing the spread of the droplets from that client. So in their own room, they don't need to wear a mask, but when they leave it, they do. Now remember, what the ramifications are if the client stops taking that TB medication. They are going to perhaps have a multi-resistant strain of TB because the TB bacterium is going to get stronger, and it's going to resist the next wave, which is actually it's not as strong of a drug, and you're going to have to put them on a different regimen of drug. Now, again, we talked about this before. Anytime you're going to give a drug, whether it's a chemotherapy, in this case it's an antibiotic chemotherapy, you need to make sure you get the sputum specimen first to make sure that when they test that sputum that it is effective, that drug is effective against what that client has. We know that it's also better to give the drugs in a single dose on an empty stomach a couple of times a week because, again, compliance is an issue. If you have a client that is that is on this drug and they're not compliant anyway, at least if you reduce the number of times that they have to comply, that would be better. The other thing, again, is when alcohol should be avoided. Remember we said it's hepatotoxic. Now, think about the type of client that we've been talking about, the transient and all of that. The alcoholic also falls into that category. So this may be a real problem for them. because they're going to increase the risk of hepatotoxicity. The next topic in this unit is pneumonia. Again, a very common recurring healthcare problem. What happens in this case is that the lung tissue, or the parenchyma of the lung, becomes inflamed. And it's usually because of some type of infection, some type of bacteria or virus that gets into the lung fields and causes this irritation. It can either be something that they got when they are out in their home, in the community, so thus the term community acquired, or a nosocomial infection. Nosocomial means that it was acquired while the client was in the hospital for another reason. They fell and broke their hip, now they're in the hospital and they get pneumonia. That's a nosocomial infection. There are several different types. This is not really something that you absolutely have to remember. I think I would skip down to this next section because the type of bacterium isn't important. It's what we do to assess and monitor the client with pneumonia that is important. Who is at risk? We know, of course, that the client who's elderly, they're very young, the client who has a suppressed immune system as a result of being on a chemotherapy or as a result of some defect or condition that they have. But we also know that cigarette smokers are also at great risk for developing pneumonia and also for developing chronic bronchitis, as we said before. So all of those chronic illnesses, anything that would suppress the immune system, that places these individuals at risk. Now, what do we normally see? The common things that you see, the very first thing, and I would star this, it is a sudden onset of fever. That doesn't mean that they have an 100.1. It means that one day they're fine, the next day their temperature is 103. In children, you may see it at 105. The cough is a very dry cough. They develop something called pleuritic pain because it's so dry and they're coughing so frequently at first that it is very painful. And so you'll see them having the need to splint their chest wall as a result of that. When they develop sputum, or when they start to develop, to put out sputum or to expel sputum, it becomes a very rusty-colored sputum if it is in fact a pneumonia. Now, the other thing you need to remember is that the sputum takes on a peculiar color when they develop an infection to begin with. And usually a strep infection will be like a greenish yellow, and a staph infection is usually a bright yellow that has bloody streaks in it. And again, that may give you an indication that this individual has a form of pneumonia. Again, sputum specimen first before we give them an antibiotic, because that's one of the nursing interventions, is to administer those antibiotics against what the bacteria is, so that, and make sure that it is not resistant to that antibiotic. The other thing that we're going to do is that we're going to give them medication for their cough. Now let's think about this for one moment. Client has a harsh cough, and you want to encourage them to expel their sputum. However, you don't want them to be up all night because their metabolic rate is up as a result of this insult to their body, so you want them to rest at night. So during the daytime, you're going to give them the expectorants to try to get rid of some of that sputum. At night, you're going to give them cough suppressants so that they don't cough, that they can get some rest, and then again give them the expectorants during the daytime. We're going to use bronchodilators with this type of client. Again, to increase that surface area to allow for more adequate air exchange for the client who has pneumonia. And of course, if they have a great deal of pain in their chest wall, we may give them some mild analgesics like Tylenol, aspirin, those types of things. Because sometimes it gets to be, if they've had this cough over a period of time, they really are quite sore. And sometimes we may even teach them how to splint if they haven't already been doing that to decrease their pain. Again, pulmonary toilet is also important, and to get them up and walk as soon as they have had antibiotics on board for about 24 hours. Get them up and walk them. Remember if you think about what is very common today, what we do for clients who are on bed rest, we need to make sure that we get them up and moving. Anytime you have a client who is immobile, think about what happens in all the body cavities. Think about what happens if blood stays in a vessel for too long, if you have urine that stays in the same part in the bladder for too long, if you have sputum that sits in the lung fields too long. What happens is a bacteria will form underneath that because it's a perfect medium for growth. So that's why we want to get them up and move them to prevent them from having any further complications, from having a thrombus in their lower extremities as a result of immobility, so we need to get them up and move them. We're also going to give them oxygen, and again, oxygen saturation will be measured, and that's usually done every 4 hours throughout the shifts. And you want to make sure that you keep them at least 95%, or unless it's ordered differently. For example, sometimes you'll see an order that will say, give oxygen to maintain O2 sat equal to or greater than 93%. So you measure the oxygen saturation, and if the oxygen is at 2 liters and the O2 sat goes down to 91, you're going to bump it up because that's what the order reads. So again, evaluating, synthesizing that information, and then performing the intervention is part of the critical thinking that nurses do when we're taking care of our clients. Again, remember that this is going to be a sudden onset, and that penicillin is the drug of choice. Now, we can use other drugs, certainly erythromycin and tetracycline. Those drugs have been used for pneumonias. The most effective drug is usually penicillin, and unless they have an allergy, we're going to give them some type of penicillin. Now, again, sometimes these clients develop allergies, so you need to penicillin, so you need to also monitor for that. Now, the only reason that we're going to talk about this next section here is because of the care of this type of client, the care of the client who has cancer of the lung. Remember earlier I talked about the fact that we saw hemoptysis when we looked at the client who has some of the lung disorders that we talked about? One of the very earliest signs that we see in a client with lung cancer is hemoptysis, or bloody sputum. Remember that usually lung cancer, it can be a primary site or a secondary site, which means that it has metastasized from someplace else, but it involves the lung field and it causes a difficulty in breathing. The unfortunate thing in this case is that the earliest sign we see is hemoptysis, and by that time the lung is involved. And usually that, although it's an early sign, it means extensive disease because it's asymptomatic in the early stages. Later on, we see all of those signs of a failing lung, wheezing, dyspnea, a cough. Sometimes, and later on, we'll see anorexia and weight loss, again because their metabolic rate is up and they're working hard at breathing, so all of their energy is going to that, and they lose their appetite, and they also lose a great deal of weight. Now, fever occurs, again, very late. So what I would like you to think about is to star coughing, wheezing, dyspnea, and number 1 is hemoptysis. Number 1 is hemoptysis. That's the first thing you're going to see. Now, again, prevention is the key here. To prevent this from occurring. So talking about smoking cessation, again, is very important. Certainly, making sure that the client knows if they do have pneumonia to prevent them from getting any other infection, so staying out of crowds and so forth, that's important. What also is important to remember here is that usually there is a pneumonectomy, or a portion of the lung is removed as a result of this cancer. Also equally important to remember is that if the client has both lungs involved, the chances are very good they will not have a pneumonectomy because the disease will removing one or a portion of the lung may compromise the other one. However, you may see them taking pieces out if, in fact, the physician thinks that it has been encapsulated. A pneumonectomy means that you've removed the entire lung, and that's the only thing that I really want to talk about here, because remember that if you have a pneumonectomy, there would be no chest tube because there isn't any lung to expand. There isn't any lung. So there wouldn't be a chest tube. However, there may be a tube, a drainage tube. You may have a tube that will collect fluid or blood that is accumulated in the chest wall, but you would not have a chest tube. Remember also that when you're positioning the client, that's important to position them on the affected side. So if they have had their right lung removed, you're going to put them on the right side. The rationale for that is in case there's any exudate bleeding or if the suture line becomes dislodged in some way, you're not going to compromise the good lung. And the other piece to that is that when the other lung is expanding, you want to make sure it fully expands to take over the work of the lung that is no longer there. So all of those things that we do to promote lung expansion and to promote good air exchange that we've talked about throughout this whole section, coughing, deep breathing, positioning, giving them oxygen, monitoring their breath sounds, all of that is still employed here with this type of client. The other thing the next thing that I'd like to talk about is I want to talk about pulmonary therapies. Pulmonary therapies are things that I think you'll see used in every institution, whether it's on an ambulatory care surgery, whether it's in a general medical surgical unit. The reason is because we are trying to prevent complications from any other disorders. Now, when we do chest physiotherapy or positioning, it's important to remember that we're going to also be using medication in this case. I want to also remind you that most often in many institutions, the nurses are no longer doing chest physiotherapy. It is done by the respiratory care technician or respiratory care personnel. However, but again, remember we talked about managing care, making sure that the client has gotten their medication and making sure that they didn't just eat breakfast and that the respiratory care person comes in and is going to perform this therapy. So you need to have an understanding of what it is, but same thing with postural drainage. So I'd like to again remind you about what we already talked about what pulmonary toilet is, so I'd like to just remind you again here that pulmonary toilet is coughing, deep breathing, and chest physiotherapy, and of course turning and positioning. The next section that we're going to talk about under respiratory is the bronchodilators. Now, I'd like you to just think about something here, because some of you may have already taken care of individuals, clients who use bronchodilators. We use them frequently, not just for clients, for example, who have asthma. Remember when we talked about asthma, I said we were going to talk about bronchodilators later, and we don't just use them for those types of individuals, but we use them for the client who has pneumonia. We may use them for the client who has another respiratory disorder, like even bronchitis, to promote adequate gas exchange. Again, it's going to dilate those bronchioles and promote air exchange. There are a number of different types of bronchodilators, and I'd like you to take a look at the picture that is going to be up on your screen now of the bronchodilator and the aero chamber, or the spacer that is used with most bronchodilators. A spacer has been used probably for about the last 6 or 8 years now. They use a spacer which is, if you take a look at the picture of it, you'll see that it is a chamber, and there are many different sizes. There are the one that you see here, there are much smaller ones. The principle is the same, and that is that you attach the metered dose inhaler to the end of it, and the client distributes that drug that's in the metered dose inhaler into the chamber. At the same time, they have their mouth on that mouthpiece, and you can see that it's narrow on one end. That's the piece that they put in their mouth, and then that's how the medication is delivered. And your role here is to teach them to make sure that they have a good seal over the mouthpiece, because remember, they're not putting their mouth now necessarily on that metered dose inhaler. They're going to be putting it on the spacer that is between them and that metered dose inhaler. So they need to make sure that they have a really good seal. They need to make sure that they expel all of their air from their lungs first and then take a nice deep breath in. And again, some of the bronchodilators are ordered routinely as prophylactic measures to prevent attacks of asthma or narrowing of the bronchus, while others are in an emergency or when you're starting to have symptoms. Now, there is a list of those in your book, and please make sure that you review those because some of them are, again, used routinely, while others are, as in the steroids, they are used during an acute exacerbation of the illness. Let's just review then to recap what we've talked about in this section. We have discussed diagnostics for the respiratory system. We've talked about the assessment that we do with regards to the respiratory system, and we've talked about some of the common recurring healthcare problems, such as pneumonia, bronchitis, chronic conditions like emphysema and asthma, and the chronic outflow limitation, or CAL, chronic airflow limitation, as well as the infectious diseases and the treatments for that, such as the types of drugs and the types of devices and or therapies that will be employed. The next thing I'd like to do then is I'd like to review some of these questions with you.